Hey everyone, thanks for joining. We're just going to give everybody a minute to get logged in here. As we wait, we're going to toss out a question. Feel free to answer it in the chat. Let us know if you had any fun travels this summer. I got to go to Canada and also explored the mountains in Tennessee. Ocean City, nice. Oh, nice. Got out of there before the hurricane hit. Thankful to hear that. Oh, I'm not sure everyone can see that. Someone went to Kiowa Island with 21 family members, but they got out right before the hurricane hit. We'll just give everybody another minute here. Colorado's beautiful. That's great. Charlottesville, that's a good one too. Okay. Well, we can jump in and just hello again. I am Kim Bazenbach, partner and director of financial planning at FSA. We're excited to partner with Margo Steinlage and Steinlage Insurance to bring avoiding Medicare mistakes in retirement. Before we jump in, I wanted to share some pretty surprising statistics from the National Council on Aging that I found. First, as most of you probably already know, like healthcare is going to be one of the biggest expenses that you need to plan for in retirement. But recent estimates indicate that a couple retiring today can average around 300,000 on healthcare expenses in retirement. Also, a lot of people are actually overpaying for coverage. In one study, researchers found that seniors spent an average of $400 per year more than they needed to, and 20% were overspending by $500 per year. That gets a little bit worse when you look just at the Medicare Advantage plan alone. A team of economists looked at that and found that only about 10% of seniors were in the optimal plan. So to say that another way, 90% of people in the Medicare Advantage plan were in the wrong plan, and people were overspending by more than $1,000 per year. And then 10% were overspending by 2,000 per year. So I think obviously that adds up. And I think we can all agree that this is a really important topic where expert advice is just so important, which is why we often team up with someone like Margo to work with our clients. And we work pretty closely where at FSA, we're going to be looking at obviously the bigger picture, including the expenses in your overall plan and how that impacts you, where Margo and her team are going to dig into the weeds of what makes the most sense for you, looking at each individual Medicare plan. So, two quick housekeeping items before we bring in Margo. First of all, there's a Q&A. So at the bottom of your screen, you'll see a question mark, and under it, it says Q&A. If you have any questions throughout the presentation, go ahead and type them in there. Margo is going to keep an eye on that and make sure she gets those answered throughout the presentation. And then secondly, we at the end of the webinar, when we kind of end it, a survey is going to pop up. And if you wouldn't mind taking a moment just to give us some feedback, let us know what you thought, what we could do differently. We'd love to hear it. So without further ado, Margo, I'm going to turn it over to you. Thanks for being here.
Awesome. Thank you, Kim and FSA for allowing me to join you all and speak on behalf of my agency, Steinlage Insurance Agency. Before I jump into the nitty-gritty of the webinar, just a little bit about myself and our agency. We are a three-generation family-owned operation. We have a main office in Missouri, and then we have 4 offices here in Virginia. And a lot of what we do is phone calls, Zooms, emails. We're kind of here however you see fit. So all of our services are free. We never charge for our reviews. So if you're on Medicare and you're looking for a review, or if you are, approaching the golden age of 65 in the near future, when you meet with myself or my team, we are never charging for our services. And we go into great detail when we do give a consultation. We're looking at your specific needs, but we're also looking at maybe a younger spouse's situation. Are you retiring and coming off of a group health plan, needing to move into Medicare? How does that position your younger spouse and maybe children that are on your group health plan? We do a lot of bridging if you're an early retiree, looking at COBRA versus ACA individual insurance to get to Medicare. You know, what are the pieces of the equation that you need versus your family members? And then if you are a high earning individual, you know, what does Medicare cost you? Is it more affordable to go Medicare at 65 or maybe stay on that employer plan if you're allowed? So another kind of bragging right that I get for working for the agency is that we're very proactive with our approach to Medicare reviews. We proactively reach out to our clients each and every year. We're doing that starting this week for the upcoming fall open enrollment. And what we like to gather with our surveys that we're sending out this week and the next few weeks is, you know, what's your up-to-date drug list? What's your up-to-date doctor list? So that when these new plans are released in the fall, we can fit you with the most optimal plan year after year. And we're doing that well in advance of the October through December timeframe. We're collecting all of this information so that we can do this in a very streamlined and efficient manner. Because we only get a 7-week window to review your coverage once you're on Medicare. So we like to be as efficient as possible. Also, one space we do not work in, unfortunately, is if you are a federal retiree. I have a great contact that I refer all of my, I guess, leads or prospects or questions that I get around the coordination of federal employee health benefits and that Medicare enrollment, or if you're TRICARE, how does Medicare fit with those federal retiree benefits? If you are somebody who is a federal retiree and you would like to get that contact information from me, her name's Tammy Flanagan, shoot me an email and either today after the webinar, just depends on how many emails I get, I will get that information over to you guys. And Tammy's fantastic. I think FSA, you guys have worked with Tammy with a few clients before as well. So here's my email, guys. It's in the chat. So feel free to shoot me an email if you are a federal retiree. Okay, so we are now working with clients all over the country. So if you live in Maryland, Virginia, DC, and then move, we are following you to help you, again, get that optimal plan selection year after year. Another question before I jump in, how am I paid? How is my agency paid? So we go out and take great pride in getting appointed with all of the national carriers. So if you're in Maryland needing a Kaiser or a Care First or a United Healthcare AARP plan, and then you move to Florida and you need a Florida Blue or a Mutual of Omaha or an Aetna or a Cigna or Humana, we write with all of these carriers. And I could care less, my team could care less if you go with carrier X, Y, or Z. Our goal is to get you with the right plan based on your specifics. Whatever plan you select, that carrier will pay us a finder's fee. So again, if you select X, Y, or Z, they're paying us a finder's fee. It's the same price for those clients to go direct to the carrier or simply use us and let us do all the headache work and hard work to get you lined up from signing up for Medicare, picking out the plan selection, and then we provide that customer support on the back end as well. So we are kind of a one-stop shop when it comes to all things Medicare and individual insurance as well. Okay, so today we're going to jump in with the general rule of Medicare, who's eligible for Medicare at 65, what are the nuances with the rules, and then second, we're going to look at what is Medicare, Medicare Advantage, Medicare Supplement, Part D drug plans. How do all of these pieces fit together? What's required? What should you be aware of when making these decisions? around Medicare plan selection. And then lastly, we're going to look at regulation shifts and this Inflation Reduction Act that was passed recently that will have drastic changes to the drug plan market in 2025, and IRMA, income-related monthly adjusted amount. So we are going to look at quite a few things today. If you want a copy of this presentation, it is being recorded, and FSA will distribute it out to you. Also, if you want a copy of the PDF of the slides, I'm happy to provide that. I'll send that over to you, Kim, after this webinar. Okay. Who is eligible for Medicare? So I like to jump in with the general rule. Generally, you have to sign up for Medicare as you approach your 65th birthday to avoid lifelong penalties. So most of you on this webinar, you're probably approaching 65, or maybe you're already 65 and you decided to work. So the general rule here is that you need to sign up as soon as you turn 65. The exception to this rule is if you or a spouse plan to work after 65. The size of that employer determines whether or not you have to sign up for Medicare at 65. So if you have a large employer that you or your spouse is working for, large employer being 20 or more full or part-time employees at that place of business. So if it's a large employer and you plan to continue working with that large employer, 20 or more employees, it doesn't matter if it's full or part-time employees. If there's 20 or more, then Medicare is optional. You don't have to sign up for Medicare at 65. If that employer-sponsored health plan with the large employer is very competitive, or maybe you have a high deductible health plan and you're maxing out the HSA and you want to stay on that health plan, you can stay on it and delay Medicare at 65 so long as it's a large employer's health plan. Okay. One red flag to watch out for here is if it's an HSA high deductible health plan and you are maxing out that HSA and you're turning 65, in most circumstances, you want to delay both Medicare Part A and Part B enrollment so you can continue contributing into your HSA until you're ready to retire at a later date. You cannot have Medicare Part A or Part B in force and contribute into your HSA and stay on that group health plan. Okay, so a lot of advice if you're planning to work around the 65th birthday and you plan to work for the foreseeable future, a lot of advice and consultations that I hop on just is around this nuance. You know, I'm working, I have a spouse that's younger, I have the younger kids on the plan, I want to continue maxing out the family amount. What do I do? Well, how big is your employer? How many employees does it employ? Okay, it's a large employer. So now we have the option. How much are you paying for your HSA? Are you hitting your max out of pocket? Are you contributing the full amount? Do you want to continue contributing the full amount? If that's the case, then you do nothing. You stay on that employer plan because it's a large employer plan and you do nothing. Medicare is an opt-in program. When you're ready to enroll in Medicare and move off that large health plan, then you sign up for Medicare Part A and Part B. A red flag to watch out for is, let's say you're working with the large employer plan and at age 70, you call me and you say, hey, Margo, I'm ready to come off this employer plan. I'm going to say, great, we need to sign up for Medicare now under your special enrollment window to avoid any penalties or gaps in coverage. And as soon as we submit your Medicare paperwork, there will be a 6-month retroactive Part A start date. When I say this, again, I'm kind of in the weeds here, but I say this because as soon as your Part A begins with that 6-month look back start date, you have to time your HSA contributions with that 6-month window. You have to consider that. So a lot of what we do is just a simple math equation. You know, you want to sign up for Medicare to begin on January 1st, and you come to me in October, we submit your Medicare paperwork in October, and the 6-month look back kicks in. That gives you a Medicare start date of April 1st of that given year. So we have to time the HSA contributions in that scenario. Now, if you are working with a small employer, fewer than 20 employees, then Medicare at 65 is required. So when you're approaching your 65th birthday and you're on a small employer's health plan, fewer than 20 employees, you need to sign up for Part A and Part B to avoid any gaps or penalties here. All right. Medicare has to be the primary payer when you have a small group health plan. So you have to sign up for Medicare. And then the next question is, do you keep that small group health plan as a secondary payer? Or do you move to the Medicare market with a supplement and a drug plan or an advantage plan? What makes the most sense here? So one person's situation can be drastically different than another person's situation, which I always get chuckles because, or like kicks out of it, because you'll talk to your best friend and your best friend has, you know, a lower income, is maybe on a 0 premium Medicare Advantage plan saying, I pay nothing. And she's super healthy, so she never uses care. She probably pays nothing. Meanwhile, you're making, you know, 750 grand as a joint filing couple, and you want to go the supplemental route, and you have very expensive drugs. So you're paying, you know, closer to 8 grand a year in Medicare, IRMA, supplement premium, and drug plan premium. So talk to an expert here, not your neighbor. I mean, I always tell clients, ask around, see what friends like, but know that your situation's likely drastically different than theirs. So, okay. What is Medicare? Medicare, if you just sign up for your red, white, and blue card, and you don't have a supplement plan, you don't have an advantage plan, what is Medicare in a nutshell? So when you turn 65 or you're coming off that large employer health plan, we help you sign up for Medicare, you get your red, white, and blue card, and you walk into the hospital with Medicare. And then let's say you need 6 months of rehab with doctors and PT and maybe an outpatient surgery after that hospital stint. What kind of coverage do you have? Well, you walk in the hospital for your hospital stay, you'll have a $1,600 deductible every 60-day occurrence. So that's a pretty large gap in Medicare that the red, white, and blue Medicare card does not cover. For that outpatient surgery, the PT, the follow-up procedures and doctor office visits, your MRIs, that's all going to fall under the medical Part B component of Medicare. Here, you'll pay a $240 deductible, and then you'll have 80% coverage for all of those medical Part B claims. So Medicare will cover roughly 80% of those bills, leaving you with a 20% residual exposure. There's no cap or ceiling on your 20% exposure. To get in the door with Medicare, most of you will pay $0 per month for the Part A hospital benefit because you or a spouse worked for 40 quarters, which is about 10 years worth of work history. Then for Part B, medical coverage under Medicare, everyone will pay a standard Part B premium of $174.70. This fluctuates year after year based on what CMS, Centers of Medicare Services, sets the standard premium at. It usually goes up or down by about $10 per month. The Part B medical premium at $174 is determined by your income. So let's say you are a single tax filer making $107,000 in modified adjusted gross income. You are deemed what's called a high earner in Medicare's eyes, and you'll see an income surcharge on that Part B premium. That's called IRMA, Income Related Monthly Adjusted Amount. So the benchmarks, it's anything above 103,000 in modified AGI for a single tax filer and 206,000 as a joint filing household. Anything over those benchmarks will add a surcharge to this Part B standard premium of 174. I will show you the chart with the IRMA brackets, income brackets, in a later slide. If you are low income or have a family member who's qualifying for Medicaid, if you are fully eligible for Medicaid, then Medicaid will come in and assist with that standard Part B premium. So again, there's gaps in your health insurance here. So with that red, white, and blue card, you have the $1,600 per 60-day occurrence, deductible exposure. You have 20% of any major medical exposure that has no cap or ceiling on it. You'll see here there's also no drug coverage naturally built in with that red, white, and blue card. There's no dental or vision. So these are the gaps of original Medicare. And this is where all the ancillary products come into play to fill these gaps in Medicare. So once you come off your group coverage or your ACA Obamacare plan and you're kind of pushed into Medicare, or you are gladly moving into Medicare because it's substantially cheaper for you, once you're in the door with Medicare, then you'll need to select a plan to fill the gaps of Medicare. And this is where you really have two pathways to choose from once you move into Medicare. So you can go with a supplemental, also known as Medigap plan, and add a Part D component to it. That's the left side of the screen. Original Medicare plus supplement and drug coverage. Or you can go with a Medicare Advantage plan. That's the right side of the screen. No matter which plan you select, you are still responsible for that Part B standard premium, the 174 per month, and any IRMA if you are a high earner. So let's look at the pros and cons of kind of each direction, because this is the most important decision that you'll make when you move into Medicare, is which direction do you go? And whatever decision you ultimately decide on, we are more than happy to get you teed up with the right level of coverage once you have all the facts. But whatever decision you are making, it can have long-term consequences. And I want to highlight those after I go into detail with each pathway here. So when you have original Medicare and you opt for a Medicare supplement and you add a standalone drug plan, Part D, you have the most comprehensive level of coverage that you can get. Medicare remains your primary payer, which means you can go to any doctor that takes Medicare. You will never ask a doctor when you have this level of coverage, do you take United Healthcare? Do you take Aetna? Those are not the questions that you're asking providers. The question is, do you take Medicare? 97% of doctors nationwide take Medicare. So you can go to any doctor that takes Medicare nationwide. When you go see your doctor, and let's say you go in the hospital with Medicare and a supplement. Your supplement, you will have a letter to your supplement. You'll have like a Plan F if you've been on Medicare for some time and you're grandfathered. You'll have a Plan G as in girl, or a Plan N as in Nancy. There's a few different options of supplemental levels, and whatever level you have, regardless if it's a United Healthcare, a Mutual, a Manhattan Life, a Aetna, or a Cigna level G, supplement G, you have the exact same level of coverage no matter which carrier you choose. So if you're on this webinar and you've been on Medicare for some time with a Plan F and you're grandfathered, you go into any Medicare provider, whether it's a hospital or a doctor, you show your Medicare card and your supplement F carrier card. you have 100% coverage for hospital and medical. Your Plan F supplement comes in and fills the gaps of original Medicare. So it pays the $1,600 per 60-day occurrence deductible for hospital. It pays, the Plan F pays the $240 per year deductible. It pays that 80%, or excuse me, 20% remaining coinsurance after Medicare pays 80. You have 100% medical and hospital with a level F supplement. Now, in 2020, 4 years ago, Congress said, and regulations shifted and eliminated Plan F to those who are new to Medicare as of 2020 and beyond. So if you are turning 65 this year or next year, the next best option of coverage that you can get is a Plan G as in girl supplement. You show your Medicare card, you show your secondary supplement G card to the doctor or the hospital, you have 100% medical and hospital, except for the Part B medical deductible, the $240 deductible for the year. So you get hit by the bus, you show your Medicare card and your supplement G card, no matter who that carrier is on the supplement, your only exposure for the year is the $240 when it comes to medical and hospitalization. Most clients opt for the Plan G because anytime you're moving supplement to supplement, F to G, G to N to F, whatever the situation is, you're most likely encountering underwriting to shop your supplemental carriers each year. So when you're new to Medicare, you're turning 65 or you're coming off this large employer plan at a later date, you have a 6-month window to enroll in any supplemental coverage without health questions. You're guaranteed acceptance into any of these plans when you're moving into Medicare for the first time. After that 6-month window closes, in most states, you have to underwrite, answer health questions, and get approved to rate shop your new supplemental plan. So if you originally went with Care First, Blue Cross Blue Shield, or Anthem, depending on your state, and now you want to go with Physicians Mutual for $30 a month in premium savings, you will need to answer health questions to make that move in most states under most circumstances. So this is just a reminder to be smart with your initial decision when choosing a supplemental plan. Now, in addition to a supplemental plan, you'll need to add a drug plan when you choose this level of coverage. There's usually about 30 different drug plans in each zip code. That's ranging from like 10 different carriers. Each carrier usually has 2 or 3 drug plan options each year. So what we do is we ask for your most up-to-date drug list, prescription list, your preferred pharmacy, and we go out and shop. We have software that allows us to shop the 30 different drug plans based on your specifics to give you a snapshot of which plan gives you the best total out-of-pocket cost when we look at premiums, deductibles, and copays at your preferred pharmacy. So whatever supplement you have, you may have a different carrier's drug plan to fill that prescription need. There's zero premium and like $4 premium drug plans out there. So if you are not on prescriptions, we still recommend picking up a drug plan to avoid any Medicare Part D penalties for going without drug coverage. Okay, if you wanted dental and vision, we have a lot of great dental and vision options that will fill that need as well. And that would be an ancillary plan that we can add. So many times I have clients who have original Medicare with a specific supplement, and then an alternative carrier's drug plan, and then an alternative carrier's dental with an alternative carrier's vision plan. And yes, it can be a little bit frustrating having 4 different cards, which you would have naturally if you went with the same level of carrier. But what you're doing is you're getting the most bang for your buck with kind of piecing together the right portfolio of products based on your needs, your dentists, your doctors, your drugs. The alternative to this robust level of coverage where you're paying up front for premiums and it allows you on the back end to have very little out-of-pocket coverage and total flexibility, the alternative route is for you to go with a Medicare Advantage plan. These are your managed care products, your HMOs, your PPOs. When you sign up for a Medicare Advantage plan, you no longer show your red, white, and blue card to the provider, to the doctor, to the hospital. You now start showing your United Healthcare HMO, your Aetna HMO, your Care First HMO, your Kaiser HMO, and you need to make sure that those providers are in network with your HMO or agree to accept your PPO if it's an out-of-network provider. So that plan, that PPO or that HMO plan that you enroll in manages your care. You still pay Medicare the $174 to hold your Medicare enrollment and eligibility, which is required for these Medicare Advantage plans. But as soon as you sign up for one of these zero premium or low premium plan selections, they are running the show. Okay. So when you sign up for these Advantage plans, they're very attractive because they're low premium, zero premium to sign up. They include free dental, $1,000 to $2,000 worth of free built-in dental. They include the drug coverage built in. They include vision. They include gym membership. They are very attractive with enticing you to sign up. And I will say 50% of the general population will sign up for a Medicare Advantage plan. But what's the kicker here? The kicker is that you are in a Medicare Advantage plan. They are managing your care. There is a push-pull relationship with you and the insurance carrier. You and your doctor feel that this surgery is best based on your circumstance, but your insurance carrier may not feel that. They may put a prior authorization on that surgery and have you and the doctor go through a little bit of red tape before you get approved for the surgery. Okay, so that's one of the biggest hurdles that I see from a back-end support is just dealing with these prior authorizations and the network restrictions. My doctor was in network in 2024, and then based on reimbursement structures and negotiations, they're not in network for 2025. Now I have to shop and optimize my plan selection another year, which is fine. These plans stay very competitive. But if you're kind of a set it and forget it person, and you have the income to support this $100 to $200 a month premium, the supplemental is going to be a little bit more headache-free in that sense. But if you are somebody who has a higher appetite for risk, they don't want to pay, $2 or $3 grand extra per year for premiums, then the Medicare Advantage plan could be a right fit for you as it builds in those extra perks and keeps your costs low. The downside being that if and when you use care, you may have pre-authorizations, you may have $3,000 or $4,000 in max out of pocket for the year. And you're limited in your doctors and network of providers that you can see. Any questions on this Medicare supplement versus Advantage plan? Because again, you're type it out in the chat if you do have questions, but your initial decision will have consequences. If you tell me and you say, Margo, I'm adamant on going with Medicare Advantage, I'm going to say, great, let's shop the 25 different plan selections in your zip code. Let's see which one fits your specific needs. But just remember, if in 3 years from now, you get hit by that bus or you develop a chronic health need and you want to go over to the supplemental plan is going to say, hey, we're requiring health questions to get you into our plan. And if you're too high health risk, you're left in that Medicare Advantage market. You're no longer going to be able to access the supplemental unless you become low health risk in the insurance carrier's eyes. And what's happening here is these supplemental plans do not abide by the ACA regulations. When you sign up for that Medicare Advantage plan, they can't ask health questions because they receive a ton of federal funding. When you sign up for your drug plan, they can't ask health questions because they receive federal funding. The supplemental can ask health questions outside of that 6-month window because they are self-funding with your premiums. There's no government funding or subsidy happening there. So it's the one area that is still requiring underwriting outside of that 6-month new to Medicare window. That's one of the biggest hangups when you're looking at these plan options, is really knowing that long-term consequence. Yeah, so we have a 60-day occurrence here. So let's say you, with that Part A deductible resetting every 60-day occurrence, if you go in the hospital in January for a COVID, you're in the hospital for 2 weeks, and now in June, you go in the hospital for a pneumonia or a heart issue, you are resetting that 60-day occurrence, and it's with 2 different medical needs. So typically, again, if you have these supplemental plans or the Advantage plan, you're not even seeing the Part A deductible come across your plate because the supplements are paying for the Part A deductible, and your Medicare Advantage plan will generally have a $200 or $300 per day copay when you go into the hospital. Another little hiccup is, how are they coding your hospital stay? Are you in under a Part B observation stay for 24 hours? Or are they flipping you to a Part A inpatient coding? So some people could go in the hospital for a day and a half and you're still not even flirting with that Part A deductible because you're not deemed an inpatient code. You're in observation status, which would be under Part B. So once you are on Medicare, you can review your coverage each fall, October 15th through December 7th. It's a 7-week window. And then with the supplemental, we can rate shop your plan anytime throughout the year, so long as you're healthy. You know, again, you're going to have to answer health questions if you want to shop your supplemental rate at a later date. So if you're on Medicare right now and you have supplemental and a drug plan and you have not shopped your supplemental in a few years, I highly recommend it. Again, Kim mentioned like a $400 or $500 is the general or average overpayment. We can usually save you that amount of money with a simple review each year, whether it's on your medication cost or your supplemental premiums. These insurance carriers want you to set it and forget it because they're slowly increasing the premiums on all of the products, or watering down the Advantage plan and creating a new Advantage plan option over here in hopes that you're just sitting on this dated, kind of older grandfathered plan. So highly recommend a review each year just to avoid any hurdles in January. You know, if you have a deductible or a drug is not being covered for the upcoming year on the formulary, you're going to want to know that in advance. And usually we can flush that out with a 20-minute review. Okay, so sorry if I feel like I'm moving through this. I could talk about this all day, but I only have an hour, so I want to get to some of the nuts and bolts of what's coming for 2025. So first, this IRMA, the income adjustment, Medicare is constantly looking at your modified adjusted gross income from the prior 2-year tax return. So anyone new to Medicare, this year in 2024 or on Medicare this year, Medicare is looking at your 2022 tax return to set your 2024 premiums. In 2025, sorry guys, in 2025, Medicare will automatically update their information with your 2023 tax return information. So you're never stuck with your prior 2-year tax return. They're constantly modifying the IRMA, the surcharge that they place on there. And in December each year, you'll get a notice from Medicare saying, hey, we see your prior two-year tax return was X. Therefore, this upcoming year, you'll see an increase or a decrease in your IRMA based on that prior 2-year look back. So here is the current 2024 IRMA brackets. This will change. Usually in November, Medicare is releasing the up-to-date IRMA brackets for the new year. So here, this chart is only good until the end of the year. I have a webinar on September 30th. If you want to join, I can share that information with you, Kim and Jim, if you want to send that invite out to clients. But we have a webinar that we're hosting for all clients and basically anyone who wants information on September 30th, so that we have the most up-to-date information going out right before the October open enrollment starts. But you'll see here, if you make over $206,000 as a couple in modified AGI, then you're going to pay, $244 a month instead of $174. If you're making above $750,000 in modified AGI as a couple, then Medicare is going to cost you about $600 a month per person in that household. So you can see here that Medicare is quite a bit more expensive if you are a high earner. And this comes into our consultation and kind of fact gathering stage. We are asking for your modified AGI for 2022, 2023, and 2024, anticipated income, so that we can see, does it make more sense to move to Medicare when you are working past 65? Or, hey, your group coverage is super competitive, stay on it. I won't know until I kind of weed out specifics, relay over your premium on your group plan, your deductible. What's your health? Are you meeting your deductible? And it's not an HSA qualified plan. Oh, you're a high earner. You have a, $6,000 exposure just to move into Medicare because of this $600 IRMA that's being added on. With the IRMA, we can appeal the IRMA when you have a life event. So if you have recently reduced your work hours or you stopped working, you're retiring. Again, Medicare has that prior 2-year look back on its information. They have no idea if you took a severance payout package and you're retiring and your income is going from $755,000 down to $255,000. They don't know this information. So when you have one of these life events, and the two most popular are going to be work reduction and work stoppage, when you have those life events, then we can immediately tell Medicare, hey, don't use my prior 2-year tax return because I did have a big year because of work. Use my anticipated income and remove my IRMA. We always recommend getting aggressive here. So if you had a home sale and it created a capital gain, or that capital gain event was somehow linked to a work reduction or retirement, you retired and you moved to a zip code or an area that had a lower cost of living, or you had to move, you were only in that state because of work. If we can link it to one of these qualified life events, then we have a very good chance of appealing. Worst case, they say no, and you're left paying the IRMA, the surcharges. Best case, whoever's processing that IRMA appeal lets it go through, and now you've reduced your IRMA for the year. There's no penalty if you underestimate your anticipated income when you're filing these appeals, and we're working with you to do this. If you underestimate your income and later turns out you made much more, in 2025 than what you stated, Medicare will simply say, hey, you owe us the difference between these brackets. You said you were going to make, 255,000, but really you made 400,000. You owe the difference between these two, about $100 a month difference. So $1,200 is what you would owe back to the government in that underestimation example. If you overestimate and later comes to find you file your tax return and you make much less than you thought you were going to make, the government generally will not credit you or pay you back overpaid IRMA in that circumstance. So this is where I love to work with FSA and our advisor partnerships and accounting firms. You may have a CPA that you bring in. We like to make sure that we're getting the most accurate anticipated income when we file these appeals so that we can make sure we're hitting the right benchmark, and we're not putting you in a position where if you overestimate, or you underestimate and later it comes to find out that you're far less than what you stated, you're not getting dinged you're not missing a credit. But again, there's no penalty if you do come in and you have to pay that difference. There's no penalty on the long term there. You just pay the difference. So again, get aggressive here. Sorry if I fumbled with my words there. It's been a long day. But this is where working with FSA and advising and wealth management groups, like we see a lot of value to working with clients on these appeals. And a lot of times clients are kind of checked out. They get the IRMA notice, they just end up paying. Or if you're collecting Social Security, you may not even know you're paying this IRMA. So it's always good to just double check. Or if you have a one-off year, again, we have to qualify the appeal with this life qualifying event. Okay, so what's happening with this Inflation Reduction Act? So right now, there's what's called this donut hole in the Medicare prescription drug world. And the most that somebody could be out of pocket under Medicare Part D for this year is about $3,300. So if you are prescribed a very expensive cancer medication, or you are on a, Dupixent, a very expensive medication for eczema, or you're on Ozempic, you're on Eliquis for your heart. These are all really expensive meds under Medicare. You will hit this $3,300 out of pocket exposure for 2024. And that's your copay responsibility when you go fill these expensive medications at the pharmacy. Once you hit the $3,300 for this year under Medicare, then your drug plan pays 100%. Next year, for 2025, Medicare is putting a $2,000 cap on all drug plans and your out-of-pocket exposure under all of these Medicare plans. So whether you go with a Part D drug plan or a Medicare Advantage plan, the most you will be out of pocket, the worst case scenario for formulary covered medicines is $2,000. This is huge regulation and life-changing for some of you on very expensive, $100,000 per year medications. So it's a great regulation. The downside here, and why we highly recommend a review this year, if you are on Medicare and you haven't, or you have reviewed in the past, do it this year. Because the downside to this regulation is now once somebody's comes out of pocket $2,000, your drug plan is responsible for the cost after you satisfy the $2,000 drug cap. So these drug plans are likely increasing their premiums to absorb this new risk. They're likely thinning out their formularies and limiting the amount of drugs on their formulary and still abiding by Medicare regulations. They may shift the tiering structure on specific medicines more so than in the past. They may put in more utilization management techniques like quantity limits, pre-authorizations, just headaches from a consumer's perspective. So again, there's positive to the regulation and there's negative. And to stay ahead of the headaches that come in January when these plans reset, I highly recommend reviewing to make sure that your drugs are covered. So if you're not a current client of ours and you're on here and you just want somebody to get eyes on your selection, feel free to shoot me an email after this webinar and I'll let you know next steps so we can collect some information from you. So here's kind of a layout. Once you hit your deductible, the most that a drug plan can charge you under any drug plan for 2025 in the deductible phase is $590. And then you go into like a copay, $10, $20, $30, $40 or 25% coinsurance phase. And once you come out of pocket, when you've met the deductible, the $590 plus your copays, when that meets $2,000 for the year, then your plan is capped and you pay nothing for the rest of the year. Also, if you are on very expensive meds, there's a new smoothing provision for 2025, which you can opt into at any point in the year. And this just streamlines your payment and approach for expensive medicine. So instead of paying at point of sale at the pharmacy, you would pay $0 at the pharmacy, and then your drug plan would bill you even amounts for your expensive meds throughout the entire year. So I think 2,000 divided by 12 is like $165, $167 spread out each month over the year to get to $2,000 if you enrolled in this payment provision for January 1. So it just helps eliminate that sticker shock when you do go fill a very expensive medicine and you pay $2,000 up front at the pharmacy to meet that $2,000 cap. This can help eliminate that. There's still a lot of nuances with this regulation and this specific provision in that regulation that are being worked out. So again, we have kind of high level views here, but until the plans release the specifics on how this actually will work, we are just kind of flying blind here. Also, if you are planning to work after 65, there will be some changes happening with creditable coverage status on your plans. So right now, to avoid any late enrollment penalty under Part D, so if you stay on that large employer plan after 65, one of the questions you'll need to ask is if it's creditable coverage. And what that means is that your high deductible health plan or your group health plan that you're staying on provides drug coverage that meets or beats what Part D under Medicare will offer. So if it meets or beats what Part D covers, then it's deemed creditable. And when you come off that employer plan at a later date when you're retiring and you move into Medicare under your special enrollment window, then you avoid any late enrollment penalties because you're coming off creditable drug coverage through your employer and moving into Medicare at that point. Because of this $2,000 cap that Medicare is now putting on drug plans, the employer plans need to satisfy that $2,000 out-of-pocket exposure and meet the creditable coverage status, which may be a little bit harder for these drug components under the employer plans. So if you get a notice from your employer saying, sorry, for 2025 or 2026, you are losing creditable coverage status, then we need to talk, because now you will need a drug plan to avoid late enrollment penalties, and it may behoove you to move into Medicare at that point. I don't foresee all employer plans losing creditable coverage status, but it's just, again, a little red flag to watch out for and to confirm if you are staying on that employer plan after 65. Always confirm the annual status. Is it creditable or is it losing creditable coverage status? Okay, how am I on time, guys? I think I have a few minutes for Q&A. But every person has a very unique circumstance. My job would be way too easy if my team could just give blanket advice for every hour phone call that we have. Usually working with my team, we're collecting your information with our schedulers reaching out, our intake form, and we're very intrusive in the sense that we need your medications. We want to know the ages of your family members. What was your income? Because all of these help us just provide that strategy as you approach your 65th birthday or decide to retire, and provide this quality advice before we even jump into specific plan selections based on those unique needs. We want to give you this not blanket, but high strategy advice first, and then look at the specifics on plan selections once it's decided you're ready to move to Medicare. You can start this process with us 2 years out, 1 year out, 3 months out. Sooner is always better, just to establish that game plan, especially if you're an early retiree and you have this COBRA gap and then Medicare need. But you guys can always reach out to us. Again, I have an entire team here. We have about 20 employees. I personally train all of my teammates, so it's quality on the front end and quality customer service on the back end. We're here to offer you a free Medicare shoulder to lean on when you're getting bombarded by solicitations left and right and lots of noise in the market. So I'll pause for now. Again, this is recorded. You can have a copy of the presentation. So feel free to ask away. So one question is, does every carrier pay the same finder's fee? Yes. So on the Medicare Advantage plan, the drug plan, they're all heavily subsidized by the government, which means they follow the rules of the government. So if you choose a 0 premium drug plan or a $100 drug plan, our agency gets paid the same. Same with the Medicare Advantage plan. The supplements are all kind of following the same curve. Our agency may get paid $5 or $10 difference, but not enough for us to say choose X over Y supplemental carrier. Also, all of my teammates are salaried. We've really removed this entire make a sale mentality. We come at this entire conversation from an education perspective. And if you sign up or you don't sign up, my team could care less because they're making a salary regardless of your ultimate decision. But what's cool is we are providing a lot of this quality information that once you have the conversation with us, you're likely working with us in some capacity. So hope that answers your question. Any other questions? I'm happy to answer. Shoot me an email. I saw here, Kim, you sent Tammy's information. She's, for those of you that are federal retirees, shoot Tammy an email. And I'm going to put my email one more time so it's front and center. Okay. I know I covered a lot. So.
Well, this is great, Margo. Thank you so much for being here. Really appreciate it. And yeah, if anyone missed anything, we'll be sending out the recording, as Margo said, and we have her contact information as well as Tammy's. So let us know if you missed any of that. And Margo, thanks again. Thanks everyone for being here. And please, as a reminder, if you don't mind filling out that survey at the end, just give us some feedback. Thanks so much.
Awesome. Thanks, guys.
Thanks.